Okay, good afternoon. I'm Laura Bryant from the Mirowitz Center. And today's program, we are presenting Dr. Ilya Bendich, Assistant Professor at Washington University School of Medicine in the Department of Orthopedic Surgery. His focus is on patients who have exhausted all non-operative measures and they're ready for surgery. Dr. Bendich utilizes evidence-based, cutting-edge techniques, including computer-assisted and robotic technologies for improved surgical outcomes. Back in February, Dr. Bendich presented a program about hip replacement surgery, and we are very happy to welcome him back for today's session on knee replacement. So I'm going to turn everything over to Dr. Bendich, and thank you very much for taking the time to share what you know today.
Thank you for that introduction, Laura, and thank you everybody for joining today. I'm happy to present on everything you need to know about knee replacements. And for those of you who were in the hip replacement section, welcome back. Always glad to have repeat viewers, and hope I can teach you as much about knee replacement as we did about hip replacement. So in terms of this presentation, this is what we'll go through. So first I'll tell you a little bit about myself. Then we'll get into talking about knee arthritis. We'll talk about the various options for treating knee arthritis, which includes non-surgical as well as surgical. And within the surgical realm, we'll talk about partial as opposed to total knee replacement. And then we'll get into discussing innovations that we're currently implementing at WashU. So we'll start with a little bit about myself. So sorry if this is a repeat again for those who joined the session back in February. I was born in Uzbekistan, and when I was very young, my family moved to New York. So I was raised in Queens and then in Long Island in a town called Great Neck. For my education, I've gone all over the US. So I did my college in the Midwest at Northwestern, and that's where I met my wife, Sarah. I did a combined medical and business school at Dartmouth. And then for my residency, I went out to San Francisco, and for my fellowship, which was in joint replacements, that was the Hospital for Special Surgery in New York City, and that's the highest volume orthopedic hospital in the world. So in terms of my practice, I'm a hip and knee replacement surgeon now at WashU, and I do primary joint replacement as well as revision joint replacement. Primary joint replacement means if you have a knee that doesn't currently have implants in it and you have arthritis, we do the primary knee replacement, and revision means if you have a failed prior joint replacements, we would do a redo surgery or revision surgery. And the real focus of my practice is on applying technology to joint replacements. So almost all of my surgeries use some form of technology, whether that's a computer navigation system or a robotic arm assisted platform. And that's for both the hip and the knee side. So that's my practice, and I see patients at Progress West in O'Fallon. I see patients at Barnes West in Creve Coeur, and I operate at Creve Coeur and also at downtown Big Barnes. So a little bit more about myself as my family. They're my support system, and I wouldn't be where I am today without them. So this is my wife, Sarah, and also our 3-year-old son, Mason. And the top right, you can see Mason's favorite thing, which is trucks. And I thought that would be an interest that would go away as he kind of got a little bit older, but it only seems to be growing. So we may need to get one of these big trucks soon. So now let's talk about the reason you're here, which is to learn about knee arthritis. So specifically, there are various forms of arthritis. There's osteoarthritis, which is what these diagrams show, but I'll also briefly talk about inflammatory arthritis, which you may have heard of, which encompasses rheumatoid arthritis or a psoriatic arthritis. And then there's also something called post-traumatic arthritis. So starting with osteoarthritis, it's really a wear and tear process of the knee. And so if you look at the diagram on the left, what you see is a normal knee joint. The knee is encompassed by the femur bone and the tibia bone, and their articulation forms the knee joint. And there's also another articulation, which is the patellofemoral joint or the kneecap, and how it slides along the femur. The ends of the bones are covered in cartilage, which is a really slick surface, and it's what allows us to have the range of motion that we do. And then in between the cartilage, And within the knee joint are soft tissue structures that also are really critical to the joint itself. And those include the meniscus, which is almost like a shock absorber in the knee. As we age and as we wear away our joints, the cartilage wears away, the meniscus wears away, and the space between that joint diminishes as those structures wear. So that's how we get to the diagram that you see on the right, where again, there's evidence of cartilage loss, the joint space has gone away, the meniscus is largely gone, and our body forms bone spurs, which are a reactive process secondary to the inflammation. So this is an osteoarthritic knee. Now, talking about some of the other forms of arthritis, an inflammatory arthritis like a rheumatoid, you would see many of these same features. You wouldn't have the bone spurs, but you would have the loss of cartilage. And that's because of almost like an autoimmune process going on. And then a post-traumatic arthritis means after a prior injury, like, if you had a fracture about your knee, if you had a prior ACL injury, anything like that, that can sometimes cause damage to the cartilage itself. And over time, that leads to an arthritic process. So first, let's get into the epidemiology, which is, how many people are affected by this, and am I affected by it? So about 15% of the population has symptomatic knee arthritis. What that means is arthritis that's present both on x-rays as well as arthritis that causes symptoms. Way more of the population actually has arthritis or the disease process going on, but they don't necessarily have symptoms going on. And like I mentioned earlier, this is largely a wear and tear process. And the prevalence of symptomatic knee arthritis has doubled since the mid-20th century, and it's expected to continue to rise. And that's largely in part due to the population aging. And now we're living longer than we have in the past, certainly than in the mid-20th century. And as the population gets more active and also heavier, all those things contribute to the wear and tear that we see on the joints, especially weight-bearing joints like the knee. So in terms of risk factors, who's at risk for this? Really, kind of everybody's at risk, but there are different factors that increase one's risk to this. Those factors include genetics. You may come from a family that has an arthritis history or an inflammatory arthritis history, but specifically for osteoarthritis as well, there is a genetic component. Obesity, as we mentioned before, the heavier we get, the more likely we are to wear through our joint. And just to give you an example, for every pound that you gain, your knee joint sees between 4 to 7 pounds of stress at the joint itself. So, the heavier we get, there's a multiplier for what the knee actually sees in terms of stress. Prior injury, as I mentioned, ACLs can lead to arthritis ACL injuries can lead to arthritis down the road, or other injuries where there's an injury directly to the cartilage itself can lead to arthritis down the road. And then high impact activities, those people who are, really active in their youth and are wearing through their joints in their youth are also at higher risk for arthritis of weight-bearing joints, the knee being one of those. And then age, the longer we live, the more likely we are to have arthritis and the more likely we are to have symptomatic arthritis. So how does arthritis present? Patients who have arthritis, especially of their knee, tend to complain of pain in one of the compartments of the knee or multiple compartments of the knee. The compartments of the knee are the anterior compartment, which is where the patella articulates with the femur, called the patellofemoral compartment. The medial compartment, which is the inside part of the knee where the femur articulates with the tibia on the inside part, and then the lateral compartment, which is on the outside part of that tibiofemoral articulation. And people can have pain right in those areas or a more diffuse general knee pain. One of the important things is knee pain can be caused by a variety of factors, not just the knee itself. It can also happen if somebody has, let's say, hip arthritis or pathology in their hip that then radiates to their knee. That can happen, as well as people with spine issues like a compressed nerve or a pinched nerve that can present as knee pain. So it's really important to figure out where that pain is coming from. And then patients can also have a loss of range of motion. So if you think about that diagram I showed before, where bone spurs form in the osteoarthritic process, those bone spurs can lead to a loss of either having a knee that's fully straight or a loss in the amount that you can bend your knee. And all that kind of amounts to a loss in functionality for people. So that's how knee arthritis tends to present. And it's really important to get the right diagnosis. So as I mentioned before, there are three things that can cause, at least three things that can cause knee pain, which again are the knee itself, the hip radiating to the knee, or the spine radiating to the knee. And so it's really important for the physician that you see to get an accurate history to understand, why did your pain start? Did you have a prior injury to your knee? Is this something that you've been taking medications for? Have you had injections that have worked for you? And then it's important to get a good exam to help differentiate that spine or hip origin from knee origin contributing to your pain. If somebody has pain with direct palpation over their joint line, it's most likely that the knee is the problem and not one of the other anatomical regions that I mentioned. And then obviously an X-ray is also really important. In my clinic, I don't treat X-rays. I treat people and then try to correlate it with X-rays. As I mentioned before, about 15% of people have symptomatic arthritis, but way more have radiographic arthritis. So if somebody has arthritis on an X-ray, but it's not causing any pain, a joint replacement is not the right answer for them, because that can create pain and create problems that weren't there before. So let's talk about some of the options for treatment. So let's say you've been now diagnosed with arthritis and you haven't tried anything for it yet. So where we would start is the boxes on the left, and we would progress over to the right with time, and as things either fail or may not provide the relief you're looking for. So looking at that top box, it's activity modification. What that means is things that hurt, don't do them. It's something that we talk about as joint replacement surgeons, but it's not realistic for a lot of people with knee arthritis. That includes walking, going up and down stairs, going on uneven surfaces. I mean, that's just part of daily life. It's hard to modify those activities. We talked before about how weight contributes to the progression of arthritis, and weight loss similarly can help alleviate knee pain because of that stress that's taken off of the joint. Medications, especially anti-inflammatory medications, like a non-steroidal anti-inflammatory, and those are like ibuprofen, Aleve, meloxicam. Medications in that category decrease the inflammation that your knee sees and helps kind of control the knee pain. And then lastly would be physical therapy. I shouldn't say lastly, within that non-surgical group would be physical therapy, which would actually probably be one of the first things you do. And the goal of physical therapy is to help strengthen the muscles around the knee joint to offload the stress the knee joint sees. If these things fail, the next step that patients in my clinic would receive would be an injection. There are a variety of injection formulations available. Very few of them have good evidence behind them. In my practice, I use mainly steroid injections, and I use it for two purposes. One is obviously to provide a symptomatic relief, but the other is for diagnosis. As I mentioned before, at least three things can cause knee pain. The knee, the hip, or the spine can all result in knee pain. And so if somebody gets relief from an injection to the knee, where they tell me all my pain is gone, or the majority of my pain is gone, I know that the knee itself is the problem. And so that provides kind of support for the diagnosis that I'm making. And then lastly, if somebody has failed all the boxes on the left, including injections, and feels they're ready for the next step, then we talk about surgery. But surgery is never my first go-to. Somebody has to have failed multiple non-surgical options before we talk about surgery. So let's talk about some of the surgical options available. So for the knee, it's partial or total knee replacements for the osteoarthritis. So as I talked about before, there are three compartments of the knee: the medial, the lateral, and the patellofemoral compartments. And so for patients who have pain or arthritis in all of those compartments, a total knee replacement is the appropriate treatment once they failed all the non-operative measures, because the total knee replacement replaces all of those compartments' cartilage with metal and then plastic. So it gets rid of the arthritic surface. For patients in whom a single compartment is arthritic and the remainder of the knee is largely pristine and not causing pain, a partial knee replacement is a possibility. And the idea behind it is to get rid of the surface that is causing the problem, and to replace that with metal and plastic while allowing the preserved surfaces to maintain. And so within my practice, of the people who come in with knee arthritis that's surgical, about 90% go on to get a total knee replacement, and 10%, 5 to 10% end up getting a partial knee replacement. But the indications for partial knee replacements are constantly expanding, and within our world, within the joint replacement world, we're studying the indications to really understand them, to see who's the ideal candidate for partial versus total. So let's talk about the recovery of a partial or total knee replacement. Why wouldn't you just get a total knee replacement and be done with it? The reason is a partial knee replacement tends to recover quicker. It's a smaller surgery. The risks overall are slightly lower in terms of percentage likelihood. And patients feel like it's a more natural feeling knee because, you know, the other parts of the knee are preserved, and the ligaments like the ACL, the PCL, et cetera, are preserved as well, providing a more natural feeling knee. As an example of what a partial versus total is, if you look at this diagram on the bottom, the left is a partial knee replacement where just the medial compartment is replaced, and the right is a total knee replacement where the entire where all the compartments of the knee are replaced. So as I mentioned earlier, the recovery for a partial is quicker than that of a total, but at around 1 year, most patients don't notice a difference. So the recovery is really in the short term. The difference in the recovery is really in the short term that it's different. On the flip side, you may ask, why not? Why wouldn't everyone just get a partial knee replacement? Well, the implant survivorship is lower with the partial knee replacement, and a large part of that is because arthritis develops in the other compartments. So if you look at this diagram, for example, where the medial compartment or the inside part of the knee is replaced, but the outside is not, over time, the outside can also develop arthritis, or the patellofemoral compartment can develop significant arthritis, and those may generate pain for people, such that just replacing this alone isn't enough. And so over time, we would want to convert this over to a total knee replacement. So it really requires kind of the ideal patient to have a partial knee replacement, and to be okay with potentially needing a redo surgery or a revision surgery sooner than one would need with a total knee replacement. So let's talk about the kind of nitty-gritty of the recovery itself. Regardless of whether we go with a partial or total knee replacement, most patients either discharge the same day, or more likely they spend one night in the hospital and discharge the next day. People are up and walking within 2 hours of surgery. They work with physical therapy, and therapy starts right after surgery. Patients are usually off of pain medications between 3 and 6 weeks after surgery. The partial knee replacement patients tend to be in the 2 to 3 week range, and total knees between 4 to 6 week range. There are no restrictions in your movements, and the only thing that I ask, and I'm sure most surgeons ask, is that you do PT, where you essentially bend your knee, straighten your knee, and make sure that that motion is preserved. And you know, the improvements that you get from knee replacement surgery are not immediate. They continue until about 6 months to a year after surgery, and that's when whatever functionality you get, whatever pain improvement you get, range of motion, et cetera, tends to kind of plateau. And after that, it's hard to kind of make any significant gains. But you know, there's a 6 month to 1 year period where you are making very significant gains. So what are the possible complications after a knee replacement? One is infection, and that's around a 1 to 2% risk. The next is stiffness, meaning that you don't have the range of motion that you want, or the range of motion that you had before surgery. I follow my patients very closely, so I see them at 2 weeks and at 6 weeks after surgery to make sure, one, the infection's not present, and two, that I check their range of motion to make sure that they're not developing stiffness. And if they are developing stiffness, we intervene and we do a procedure called a manipulation under anesthesia, where we put the patient to sleep and manually break up the scar tissue or the adhesions that are forming. Other risks are components can loosen or can fail. And this is something that tends to happen over time. The next is instability, where the knee either doesn't feel as stable to you as it did before surgery, or some components are sometimes modular or rotating, and they can spin out or dislocate. That's rare. And then the next kind of big thing is some patients after a knee replacement do have persistent pain and tends to be in the front part of the knee. So something that's important to note is if you do have friends who have had hip replacements, a knee is not like a hip. Even with perfect x-rays, up to 20% of patients tend to be dissatisfied with total knee replacement. And within our field, we're really studying to figure out why that may be. My suspicion is that we may be operating on people too early. Like I mentioned before, 3 things can cause knee pain, and it may be that we are operating on people with mild or moderate knee arthritis, where their pain, at least a portion of their knee pain, may be coming from elsewhere. Another thing that I think may be contributing is that knee replacements make noise. They click, they clank, they feel somewhat mechanical, and whereas a hip does not. And so some people may not like that. And then, as I mentioned, there could be some persistent anterior knee pain that happens after a knee replacement. So this is something we're working to improve. And then with partial knee replacement, the thing you really need to be aware of and okay with is that there may be progression of arthritis in the other compartments down the road years later, which would necessitate a redo surgery or a revision to a total knee replacement. So now that you understand kind of the basics of a partial and total knee replacement and what you can expect, let's talk about some of the innovations that are going on in this field. Specifically, kind of things that are gaining in popularity and I think make a pretty significant difference, in my opinion, is the use of technology within joint replacement. And that includes robotics as well as computer navigation systems. So this is a study that I published last year looking at utilization and 90-day complication rates for patients undergoing knee replacement, either without any technology, with computer navigation, or with robotics. And this was looking at the US from 2010 to 2018. And this was using a national database. So what this pie chart shows is that 7% of all total knee replacements that went in between that time period of 2010 to 2018 used technology. So 93% did not. And looking at that further, a really small sliver, 5% of that 7% technology-based pool utilized robotics. So robotics is really fairly rare, at least in this time period. So now looking at some other data, looking at this graph on the left, it shows the trend in the use of technology over time. So the orange dots are robotics, the gray dot is computer navigation, and yellow is technology overall. And you can see that there's definitely been some increase since 2010, but it's not dramatic. By 2018, fewer than 2% of all knee replacements done in the US used a robot. Now, if we look at this graph on the right, this breaks the data out by region of the country. And the blue portion of this graph is conventional knee replacement, meaning knee replacement that doesn't use any technology. The orange is knee replacement that used computer navigation systems. And the gray is the portion that used robotic assistance. And so what we can see here is that in the Midwest, there's very little robotic use over that time period. And over 95% of the knees down in the Midwest used no technology at all. So then I looked at the complication rates after surgery to see if there was a difference between the robotic, the computer navigated, and the conventional knee groups. And what you can see here is over that time period, the percent of complications in 90 days was about 1.5% for robotics and about 2.5% for conventional knee, and slightly lower for computer nav. So there was a difference between these in this database that we looked at. Now looking at the partial knee side, here at WashU, we've kind of been studying partial knee replacements and how well they are aligned on X-ray. And some of my partners published this, what is becoming a landmark study, showing a very high prevalence of X-ray outliers in partial knee replacements that are put in manually. Meaning that when we use our conventional jigs, what we found is that around 12% of all partial knee replacements are put in meeting every single radiographic parameter that a surgeon would strive for. That's 12%, meaning 88% miss the mark on at least one of the radiographic parameters. So because of this data at WashU for partial knees, anyone who currently does them is using a robot. And then we studied what if we do that same study looking at robotic partial knee replacements, and we found the vast majority of partial knee replacements that go in with a robot hit the radiographic markers. We haven't published this portion yet, but what we found is at 3 years, there's half the rate of revision, meaning redo surgeries for partial knees that are done with a robot compared to manually. But that is something we are currently writing up. So now that I've talked to you about the technology piece, what does it actually look like? This is a picture of what robotic assisted partial knee replacement looks like, and the total knee part looks very similar. So what we do is we get a CT scan of your bone before the surgery, and everybody's bone is a little bit different. So the CT scan allows us to plan your surgery in 3 dimensions. We then plan out your surgery in 3 dimensions. We put the implants where we think they're going to, serve you best and provide a good radiographic outcome as well. And then in surgery, we assess the tensioning of your ligaments and make slight changes on the fly of where those implants are going to be put. And then the robotic arm, which is this white arm here, that's attached in this situation to a burr, but can also be attached to a saw. It helps execute the plan that we came up with and that we modified. And so it allows us to accurately execute our plan. And then I also separately want to talk about even though it's the knee talk, I just want to mention the hip piece. In February, we had talked about that hip robotics was coming to WashU. And as of May, we are now doing robotic hip replacements. And as of yet, I am currently the only one doing it, but I have a feeling that's going to expand. So the robotic hip replacement program is also up and running. And what that is uses that same robotic arm, this white robotic arm, and it allows us to execute our plan right here. Again, fairly precisely in terms of where we put the components for your hip replacement. So I hope that was informative. We talked about knee replacements. We talked about what technology can offer in knee replacements. And then I provided a brief update on the HIP program, just to kind of close the loop on the talk from February. But again, my name is Ilya Bendich. I'm an attending orthopedic surgeon at WashU. My practice is in hip and knee replacement, and my main focus is using technology for hip and knee replacement. So I'm happy to answer any questions at this point.
Thank you, Dr. Bendich. We do have a couple of questions in the chat room. I don't know if you can see them or not. One is, I think you've already talked a little bit about this knee joint injections of stem cells or other biologics.
Yeah, so I just think a lot of people offer stem cell injections, but there isn't a lot of data on it yet. And so I don't offer it in my practice until the data is there. The other piece of that is there's another type of injection called PRP, or platelet-rich plasma. And there is data for that, but it's for mild osteoarthritis. So once somebody progresses beyond the mild category, which if you're at the stage of where you're seeing me, most people are not in that mild category. PRP does not offer benefit beyond patients who have mild, but for people with mild arthritis, it does seem to offer a benefit.
Okay, and then there's another question about asking for a comment. I don't know if I'm going to pronounce this correctly. A vascular necrosis, is that correct? Yeah, vascular necrosis. It's definitely a problem in both hip and knee, and it can affect the bone kind of anywhere. For patients with avascular necrosis, I tend to manage it the same way that I do with my osteoarthritis patients. So we try conservative methods. The only surgical aspect that changes for me is I tend not to do partial knee replacements for people with avascular necrosis. I tend to do total knee replacements. And sometimes I do require revision style knee replacements if for whatever reason I'm concerned about the stability of the implant. Okay, so you're getting more questions. Cortisone shots. Yeah. And, go ahead. And then there was one other question about hyaluronic acid. Yeah. So okay. Great questions. All these injectables are used. They have mixed evidence on them. Steroid shots are the only ones. The cortisone shots are the only ones I use in my practice. And again, I use them because
I kind of follow our Academy guidelines, and of the injectables, that's the only one that's recommended as of now based on the current guidelines. And, I also mainly use it for diagnosis. So if I have a question of where's the pain coming from, is it the hip, the knee, the spine, I will inject with steroid to see if there's an improvement in that pain. So it's for two purposes for me, whereas the other injectables, for my purposes, don't provide that. And in terms of how frequently can you get a steroid injection, the literature is kind of changing on this, but as of now, we're all at WashU at least going by the guidelines of every 3 months, and most people will not do it within every 3 months.
Okay.
So then hyaluronic acid is the next question.
Yes.
So that is an injectable. It's also used. The evidence for it is not great, so it's not currently recommended by our academy. But I will say that there's really no downside to using it, aside from the injection, the potential cost. But for a subset of patients, it works, but for some it doesn't. It's almost like flip a coin to know if it's going to work or not. So as a result, I don't do it in my practice, but some of my partners do.
You have a follow-up question. Oops, I'm sorry. On the necrosis, do the surgical treatments actually lead to a cure or just relief from pain before the replacement?
Yeah, so everyone's different with avascular necrosis, but I think it's unlikely from these procedures to get a cure, at least with what we're talking about. The goal of symptom management is to make sure the pain is the pain is manageable. If somebody then has, a depression in their articular surface, or something else that'll be concerning for me, and non-op is no longer working, we move on to surgery. But even in the condition of osteoarthritis, we're not looking for a cure for osteoarthritis. It's all symptom management. Or even in rheumatoid arthritis, it's effectively symptom management in the knee. But the caveat for rheumatoid is there are medications that can slow the disease process down.
Okay, you have another question this time about what do you suggest for a patient who's bone on bone and has gotten blood clots during surgery? For instance, clots after hip surgery.
It's all patient. It's all individualized. Okay, it depends on your history. If you have something that's concerning, I would send you to a hematologist beforehand to get their recommendations. But for somebody who has prior clots, we put you on a stronger blood thinner after surgery. And then in certain cases, if somebody's really high risk for blood clots, we have something called an IVC filter put in, which is a filter that goes into one of your major veins, such that if you were to have a clot and it were to travel up, what we wouldn't want is for that clot to get to your lungs, because that's potentially life-threatening. And this filter would lower your risk of having a life-threatening clot to your lungs.
Okay, another question. Is it true that subsequent cortisone shots are less effective than earlier ones? In other words, does the effectiveness decrease as time goes on?
I've never actually seen a study on that, but in my own practice, that's definitely what I see is patients they've had the best results with the first 2 injections, and then over time they diminish. And I don't know if that's because of a medication effect or that the disease is just progressing. I don't know why, but I have seen that in my own practice.
Okay. Does anyone else have any questions, either on the chat room, or raise your hand, manually or digitally, and let us know if you have questions? Anyone else? Okay, I think that wraps it up today. Dr. Bendich, this was just a really amazing presentation, really interesting, and your expertise is much appreciated.
Thank you for the opportunity, and everybody have a great afternoon.
Thank you for your time. We really appreciate it.
Thank you. Take care.
Okay, goodbye. Oh, wait, it looks like there's one person who has one more question. Oh, changed her mind maybe. Okay, we're gonna say goodbye. Thank you, everyone. Good afternoon. Bye-bye.